of self-discovery. I found one column to be particularly relevant to today's topic of homelessness and compassion. In it, Sammy described how he threw out a hat on the street and started playing cello for some extra money. He was doing well, but then he noticed that some beggars were there and felt guilty because they needed the donations to feed their families, while most of the tourists were giving money to him. So the next day, Sammy put out a sign that read, Magen David Adon, which is Israel's national ambulance and disaster relief organization, and he began playing for charity. And one day, Sammy was quite moved when a beggar stood before him, watched him play, and then put a coin in the hat. Describing this experience, Sammy wrote, and I quote, I met a man who, rather than losing himself in a dark world of overbearing hardship, managed to hold root in the greater people of Am Yisrael. Supporting needy Jews in the north became no different from supporting his hungry family at home. I have come to see that what makes this old city so special to me is neither the architecture nor the history, rather the people and their collective identity are the essence of this place I now call home, close quote. So David and Claire, I want to thank you so much for making this lecture possible, for turning your grief into something so positive, something that will enable many others to learn in the future. It is through your generosity and love that Sammy's memory and legacy will continue on here at the MGH and will help us teach important lessons to many more people far into the future. So thank you so much.
Thank you, Dr. Slavin, for opening today's lecture. I'd now like to take a moment and invite a member of the Fisher family, Sammy's brother, Jonathan, to say a few words.
Thanks, Dr. Slavin, and thanks, Dr. Smith. Hi, everyone. Good morning from where I am here in Los Angeles. I'll take a few minutes to share some of my fond memories of Sammy, things that probably many of you don't know about him. And I know there's a lot of course, the dermatology, the German Path faculty at MGH, and then a lot of my family members, my grandparents are here, and a lot of Sammy's friends, and by virtue, our friends. So thank you so much to all of you for coming out this morning, this afternoon. So I wanted to start by talking about how Sammy taught me to pursue my passions, and he was very purposeful in pursuing his passions in life. So Sammy was my younger brother. He was a little more than a year younger than me, but he taught me quite a lot when we were growing up together about myself and about the world. And so I remember that when I was a freshman at Yale, I was very ambitious with all the extracurricular activities I was taking up. And one of them that I really took seriously was the student newspaper there. I was working in the layout, the production and design for the Yale Daily newspaper. And their hours there, I think it was 2 or 3 nights a week from 8 p.m. to midnight were the hours that they worked on production of the newspaper. And I was kind of complaining a little about this to Sammy when he was asking me how college was going. And he distracted me a little and asked me about other aspects of my life. He asked me, how classes were going, and he asked me how my music was going. I am a pianist, and he wanted to know, was I getting to play enough music? And when I told him that I really didn't have time to play piano anymore because of all this time in the newspaper, he pointed out the irony to me that I was investing so much time in this newspaper that I wasn't as interested in, and kind of to the detriment of other hobbies that I was more interested in, that I was more passionate about. And so I, of course, finished that assignment at the newspaper, but then didn't continue the next semester, and took it upon myself to try to play music more and start a band at Yale. Just an example of Sammy kind of realigning my priorities, and I think reminding me that we shouldn't take our hobbies for granted and take our interests for granted, but always kind of reassess our priorities and do what we want to be doing. So he had a very keen sense of his own priorities, and Sammy lived very purposefully, always pursuing what he thought was important. I remember Sammy used to lament to me that he would make all kinds of plans with his friends while he was a college student at Harvard, and then sometimes his friends would feel overwhelmed by their work and cancel last minute. You know, it might be they have a midterm coming up or a final, and they would push it off the plans to get together. And that really bugged Sammy, not because he felt like people shouldn't take their schoolwork seriously, but that they should be taking their friendships seriously. And Sammy was no slouch when it came to his own schoolwork, and he worked absurdly hard in college. He earned the title of John Harvard Scholar. He was in the top 5% of his Harvard class. He also had a teaching award for teaching statistics as a teaching fellow. He was the president of the Harvard Hillel, obviously very accomplished, and we all looked up to him. But most of all, Sammy was very mindful in ordering his priorities, and he was very purposeful in pursuing his priorities. So his death really was a stark reminder to all of us of the importance of living the life that we want to live and to pursue our passions. And then on a separate note, I wanted to talk about something that I haven't really thought of for a while, but I was flipping through some old pictures of Sammy and the family, and I remembered how interested Sammy was in fashion, and how much he would think about that and have fun dressing up. So it turned out to be a hobby that, in my opinion, really didn't extend much to the rest of the family, the talent that didn't extend much to the rest of us. But I was thinking about why fashion was so important to Sammy, and I think it was because of maturity. It was kind of a sign of maturity to Sammy to dress up well, to dress as an adult, and he really enjoyed dressing the part. He's always the fanciest person in the room, and I think he liked to stand out a little bit from the crowd, but not in a bold or kind of obnoxious way, but more so in a mature way, kind of as an example. I think to an outsider, this habit of dressing up and the emphasis on fashion probably seemed a little bit pretentious, and my friends would sometimes comment on that to me. But we who knew him best know that that was not the case at all. And he actually did not take himself very seriously. But it was kind of just fun dressing up. I think it was at the Natick Mall where there was a Brooks Brothers junior store, where Sammy loved to dress up. That was kind of his favorite clothing store because he could get, these fancy Brooks Brothers button shirts for a quarter of the price of the real version of the next door adult store. And of course, these shirts had kind of a junior looking collar. I think the collar was just half the thickness of the adult collar. And in a way, I think Sammy really liked that because, again, it kind of stood out a little bit, and it was a reminder of the good deal that he was getting on these shirts. And then on a related note, Sammy was very fond of whiskey and a lot of fine foods and other tastes. And the story of one particular Friday night at Shabbos after dinner, Sammy had brought home a fancy green label whiskey from a New Hampshire liquor store. And he was pouring the glasses, I think he poured 4 glasses of the whiskey. And when I reached over clumsily, my elbow slipped on the tablecloth and I knocked over all the glasses and the whiskey just spilled. So probably like a quarter of that brand new bottle that he had bought just spilled right onto the table. And Sammy, without batting an eye, just picked the glasses back up again and poured them. And he said, "It's okay, Jonathan, it's just whiskey." So Sammy was no stranger to luxury and material pleasures in life, but in the end, his love and connection to his family and his friends and people all around him always came first. So finally, I just wanted to make a connection to dermatology. And this is what I thought of. One of my attendings at UCLA likes to, as a way of brushing off minor complaints, she'll call a seborrheic keratosis a sign of wisdom and maturity. She'll say, "Oh, you don't need to worry about that. It's a sign of wisdom and maturity." And for those of you who don't know, these are just very common benign growths that people get essentially with age. Now, Sammy didn't grow old enough to grow any SKs, but to those who knew him, he was our sign of wisdom and maturity. We were so pained by his loss, but we try to keep the mature and wise outlook that he taught us to always be appreciative for what we have and to be focused on the love around us. I want to thank you all again for being here today, and I'll now hand the floor back to Dr. Smith.
Thank you, Jonathan. Thank you for speaking on behalf of your family and also for sharing with us those stories so that we can also share in knowing a little about Sammy. With that, it is now my distinct honor to introduce our speaker today. Dr. Jennifer Tan is well known to us all here as a member of our faculty. Dr. Tan obtained her medical degree from Robert Wood Johnson Medical School and then trained in dermatology here as part of the Harvard Medical School residency program, of which she was the chief resident in her final year. She has held appointments at Brigham and Women's, Boston Children's Hospital, Mass General, and Healthcare for the Homeless over the years. But throughout these different appointments, the common thread of Dr. Tan's career has been in the diagnosis and management of cutaneous disorders arising in adults and children experiencing homelessness. And she has both published work in the scientific literature and spoken nationally on this topic. She's a member here of the MGH Executive Committee on Community Health and the American Academy of Dermatology's Community Outreach Programs Committee. She is also the director of the dermatology program at Boston Healthcare for the Homeless, which she co-founded 10 years ago and integrated into the dermatology residency. Most importantly, Dr. Tan is a tireless and inspiring advocate and for the medical care of this homeless population. And it's therefore particularly appropriate that she is the inaugural speaker of this special lecture series, as the Fisher family have indicated that her work would be immensely meaningful to Samuel Fisher, in whose name this lecture is endowed. So with that, I'd like to welcome Dr. Tan, who will be speaking on this work in a talk entitled Building Bridges Between Dermatology and Homeless Medicine, Compassion, Partnership, and Legacy. Dr. Tan.
Thank you, Gideon, for that introduction. And thank you all for taking the time to join us for the first Samuel Fisher Memorial Lecture. I am truly grateful to David and Claire and the Fisher family for inviting me here today, and I'm honored to speak in memory of Sammy. I appreciate the opportunity to share with you my experiences with building bridges between dermatology and homeless medicine over the past 10 years. We will particularly focus on the lessons that I've learned through so many examples of compassion, partnership, and legacy. I'm on the scientific advisory board for this skincare company, but is not relevant to this discussion. And I never had the opportunity to meet Sammy, but can appreciate and be inspired by all that he accomplished during his life. Sammy is remembered as a charismatic leader who was able to bridge gaps between different groups within the Hillel community, of which he was former president. He was recognized for always doing for others, and this included adults experiencing homelessness in his Cambridge neighborhood, whom he would buy dinner for and offer friendship. He would even invite them to share dinner with him at the local IHOP. Sammy recognized the common humanity that binds us together, and it is that humanity that should propel us to take care of each other, recognizing that we are all born with different opportunities and privilege. It's an honor to be here today to tell you about skin disease in a very special population. While we reflect on the public health crisis that is homelessness in America, we will remember Sammy's quiet dedication to helping his vulnerable neighbors. The themes of today's talk are also themes that characterize Sammy's life: compassion, partnership, and legacy. We will use these themes to frame our medical discussion of homelessness in America, dermatologic disease in patients experiencing homelessness, and our collaborative dermatology program. First, I'd like to begin by introducing you to Dr. Jim O'Connell, who's joining us today. If you could define compassion with a human face, it would be Jim. Jim is assistant professor of medicine at Harvard Medical School and Boston University, and founder and president of Boston Healthcare for the Homeless program, which I will fondly refer to as BHCHP. He is an innovator in the field of homeless medicine and is beyond dedicated to his patients, each of whom he knows by name. Jim sees patients wherever they need to be seen, in doorways, under bridges, and on the streets. A true humanist and gentle yet brilliant soul, Jim has been widely recognized for his ability to convey passion and respect during the most challenging of patient interactions. It was in 1985 that Jim decided to dedicate his career to caring for patients experiencing homelessness by founding BHCHP, with the mission to provide access to the highest quality healthcare for all men, women, and children experiencing homelessness in the Boston area. His dream, which started out of a small shelter, now provides care to over 11,000 patients in the greater Boston area, and he has over 500 employees and 65 full-time healthcare providers on staff. It is a unique and impactful healthcare model, arguably the only one of its kind in the country, if not the world. You may ask, with so many hospitals in Boston, why is it so important to have a homeless healthcare system? Well, let's take a step back and discuss homelessness in America. The condition of homelessness is complex, involving an interplay between shortcomings in housing, education, welfare, and healthcare. Severe poverty, the opioid epidemic, and climate change also contribute. And the faces of this population are diverse. The stereotypical face of a nomadic person with mental illness or substance use disorder is now in the company of the working elderly population, veterans, and families. About 30% of the population experiencing homelessness are families and children. Over recent years, older adults and employed persons are experiencing housing instability. It can really happen to anyone, as we've seen during the COVID-19 pandemic. The preferred term to use in this population is persons experiencing homelessness, because homelessness is an experience, not a defining or lasting trait. In 2020, over 580,000 Americans experienced homelessness.
They were a little difficult.
What's that? Can everyone hear me okay? Okay. And nearly 40% of these patients were unsheltered, and 30% experienced homelessness as a family. After steady reductions in homelessness between 2010 and 2016, homelessness has increased over the last four consecutive years. This increase is largely due to unsheltered individuals. And these numbers were actually gathered pre-COVID, so this year's data will be interesting to see, particularly given the current affordable housing crisis. People of color, particularly those who identify as African American, Native American, and Pacific Islanders, are significantly overrepresented among people experiencing homelessness. I find the data on this slide to be alarming. 2.3 to 3.5 million Americans experience homeless each year, and patients face a complex burden of medical comorbidities, including substance use disorders, infections including hepatitis, tuberculosis, and AIDS, psychiatric disease, and many are the victims of violence. Cancers are frequently diagnosed in advanced stages, and taken together, the condition of homelessness leads to a mortality 3 to 9 times that of the general population. Our patients experience unique obstacles to care, including barriers in communication, such as having no phone or no permanent address. There are housing and transportation barriers, including having to be at a shelter at a given time to acquire a bed for the evening. Social barriers include fear of stigmatization if a patient were to come to an unfamiliar office, and the daily struggle for shelter and food can overshadow medical needs and preventative health needs, leading to our patients overutilizing emergency and inpatient services 5 times more frequently than that of the general population. So how do we overcome these barriers and create accessible care in a non-stigmatizing environment? Homeless medicine is a solution. And this involves carefully coordinated networks of shelter-based clinics, soup kitchens, street teams, clinician and social workers that create patient-centered care models. The idea is that care is brought directly to patients and that the networks are devised to help patients navigate our very complicated medical systems. The HCHP is an example of an incredibly successful provider of homeless medicine and is considered the gold standard in the United States. There is a main health facility where patients may enjoy a very robust outpatient service, including primary care, behavioral health care, addiction services, social work and case management, pharmacy, dentistry, and dermatology. We are proud to be one of the few medical subspecialties currently providing care at the main health center. The HCHP also has a mobile health van, which is partnered with the harm reduction service and a needle exchange program, and also has a street team. This dedicated team of providers, which includes Jim, often know every detail about their patients' lives, including where in Boston to find them their patients on a given night. Perhaps one of the most unique features of BHCHP is the Barbara McGinnis House, a 104-bed medical respite center located on the top floors of the main medical facility. This respite center was named after legendary nurse and teacher Barbara McGinnis. Medical respite centers have innovated the delivery of care to persons experiencing homelessness and are where patients who are transitioning from inpatient care to being back on the streets or back in the shelters are able to receive medical services. There are over 100 medical respite centers across the United States, and they have really revolutionized care. We provide consultative services to the patients of the respite center, and we also conduct skin cancer screenings on an annual basis. Regarding dermatology-specific uses of the respite center, we are able to admit patients for skin cancer surgery during the pre and post-op period, and we're also able to admit patients for management of diffuse inflammatory disease and wounds. And this is where the partnership piece of our story begins in the BHCHP Medical Respite Center in 1998. As you may know, Dr. Ernesto Gonzalez, professor of dermatology at Harvard Medical School and Mass General, is the founding father of this partnership. Ernesto came from a poor family in Aguadilla, Puerto Rico, and his own mother experienced homelessness. For the past 25 years, he has tirelessly and quietly provided dermatologic care for BHCHP patients, first rounding with Jim in the Medical Respite Center on a monthly basis. It's easy for me to see why Jim and Ernesto are friends. Like Jim, Ernesto is the type of human who steadily inspires through his strong sense of character, compassion, and unyielding commitment to social justice. I'd like to acknowledge and thank Ernesto for building a legacy committed to promoting diversity in dermatology, pioneering clinical innovation, and serving the most vulnerable members of our society. He laid the groundwork for this partnership, and his mentorship has been really invaluable to me. It was Ernesto, along with Dr. Richard Johnson, who published the first descriptive study of skin disease in patients experiencing homelessness, with findings summarized here. Dr. Johnson was one of the first faculty members to volunteer to help our clinic back in 2009 when I was a resident, and we still have patients asking for his intralesional triamcinolone and Castellani's paint. What this group found was that, and what has been substantiated in the literature since, is that infections are common, including fungal, bacterial, and ectoparasitic processes. Inflammatory conditions are commonly observed, including psoriasis, seborrheic dermatitis, and stasis dermatitis. And physical injuries, such as trauma, scars, and abrasions, also commonly occur. The recent literature has validated their findings and has also shown that patients experiencing homelessness have higher rates of group A strep skin abscesses. This is helpful to know when choosing antimicrobial coverage for these patients. There are also higher rates of ectoparasitic disease in unsheltered patients, which may be due to the lack of access to hygienic facilities. Dermatologic complaints involving the lower leg are common, likely due to the amount of time that our patients spend on their feet, as well as lack of good foot care, chronic venous stasis, and chronic lymphedema. Patients experiencing homelessness are likely a high-risk population for the development of skin cancer, and there is lack of knowledge of skin preventative practices in this population. There are various dermatology-specific barriers to care, including access, transportation, and living issues. From patient feedback, we found the most pressing to be the cost of over-the-counter medications, which, as you know, are at the crux of skincare management. Patients have expressed discomfort with dislocation as they prefer to see us at BHCHP rather than at our university-based practices. And living barriers include the inability to store medications or the need to carry all of their medications with them throughout the day. There is also sometimes difficulty applying topical medications when they are on the streets or in a crowded shelter. And medications are often lost or stolen. Despite these barriers, patients make it through our doors and we see a lot of interesting skin disease. And we've learned a tremendous amount from our patients. I'd like to take a moment to share some of the clinical pearls that we've learned over the years. One thing is that inflammatory skin conditions are common, but sometimes neglected, resulting in widespread disease at presentation. We've also noted that lack of access to hygienic facilities may result in avoidable hospitalizations for widespread infection, such as this patient with diabetes and MRSA furunculosis and impetigo in one of our pediatric patients. Environmental exposures result in complicated wounds, such as seen in this patient with a sunburn after he fell asleep outdoors. This is a fire injury that we observed on a patient's abdomen. And this is cold injury in a patient with cryoglobulinemia who developed frostbite. We've noticed that increased sun exposure leads to skin cancers presenting in advanced stages, such as this 11mm melanoma, a squamous cell carcinoma presenting with a very large cutaneous horn, and a multifocal squamous cell arising in a scar. We've observed 2 cases of fatal metastatic basal cell skin cancer in patients. And that while both of these patients had underlying psychiatric disease and had avoided care for many years, they also had lack of insight into the severity of their disease and the potential for a fatal outcome. And it really was engaging with their primary care, the relationship between primary care providers and dermatology that eventually helped these patients seek treatment. We've also noticed that uncommon conditions may remain undiagnosed without dermatology consultation, including this patient with vasculitis, patient with neurofibromatosis, and a patient with Darius disease. And we've observed that skin disease can be controlled with access to dermatologic care. These are 2 of my patients with extensive psoriasis, both controlled with methotrexate therapy. There are a lot of misconceptions that patients experiencing homelessness are nomadic or incapable of following up, but I would say that my experience has been quite the opposite. My patients often come to clinic when they don't have a scheduled visit. I think sometimes they just like to talk in the form of a therapeutic encounter. In addition to the pearls that we've learned from seeing these patients, we now have a more precise understanding of the skin disease observed in our patients through the data acquired over a 7-year period. Our demographics are consistent with what we see in Massachusetts amongst the population of people experiencing homelessness. And we see that 535 patients made over 750 dermatology visits over a 7-year period. Of these patients, about 50% were residing in shelters or supportive housing, and 94% had public insurance. The medical comorbidities are shown here, including tobacco, alcohol, and substance use disorders. You'll note that over a quarter of our patients are hepatitis C positive, and 3/4 had a psychiatric comorbidity other than substance use disorder. So this includes anxiety and depression. For the dermatologic diagnoses, you'll note that inflammatory skin conditions are most commonly observed, especially psoriasis, eczema, and seborrheic dermatitis, and infections accounted for about 1/3 of visits, while skin cancer accounted for a smaller percentage. Interestingly, when you look at infestations such as scabies and lice, the percentage is much lower, suggesting that the primary care providers at BHCHP feel very comfortable with managing these conditions. We also had similar findings for physical diagnoses such as frostbite, as we were only asked to see 3 patients during the 7-year period. Consistent with these findings, in an informal survey of 25 primary care providers at BHCHP, we found that there was much more comfort in diagnosing and caring for infestations such as scabies than diagnosing and managing skin cancer and inflammatory conditions. And the data shown here suggests the important role of the dermatologist in caring for patients experiencing homelessness. Out of 106 visits in a 1-year period, 77% of referral diagnoses were changed following dermatology consultation. And among patients whose diagnoses did not change, an additional diagnosis was given to over half of those patients. So I'd like to offer some tips for providing dermatologic care in patients experiencing homelessness. First, Consider assessing for housing status along with other social determinants of health. This can be done through a simple question such as, what is your housing situation today? Or where will you be staying this evening? Be sensitive. Many patients have experienced violence in the past, and they might not feel comfortable or might not be quite ready to have a full body skin exam during their first encounter. We are fortunate that 94% of our patients are enrolled in Mass Health, so we utilize the Mass Health formulary quite frequently, as well as the Target $4 list. We work closely with our primary care providers, especially to coordinate and discuss difficult diagnoses with patients, particularly in our patients who have a comorbid psychiatric disease. We also try to devise a follow-up plan at the end of the visit, including the time that they will be scheduled to see us again and a way to discuss biopsy results if pathology was sent. Our patients really like to know when they will be seen again, and this allows them to trust that we will continue to be there for them. Remember that dermatologists play an important role in building trust in the medical system. And what we've observed over time is that dermatology might be an important and interesting point of engagement with the medical system and our patients. Our patients often require more time. Some of our patients bring everything that they own to their visit. It might be the only time of the day that they are identified by name or have the opportunity to have a conversation with another person, which really brings me to the next point, that sometimes a therapeutic encounter is what patients are really seeking. They might just need somebody to listen. Our residents observe us asking our patients about their stories and learning about their struggles with homelessness. We really try to go the extra mile to show empathy, to make patients comfortable, and to help them navigate the challenge of the healthcare system. And their stories of perseverance and hope really enrich our lives tremendously. We must also consider the patient's living environment when prescribing dermatologic treatment. You may need to consider, are they living on the streets or are they living in a shelter? And how do they manage their personal belongings? While a large tub of triamcinolone may help to last a lot longer, it may be more helpful for a patient to actually have smaller tubes to carry with them throughout the day. Oral rather than topical treatment are sometimes appropriate, especially oral ivermectin for scabies and oral antibiotics, as topical application can be incredibly challenging when a patient is either living on the streets or in a crowded shelter. It's helpful to assess for underlying conditions in the setting of recurrent infection. Does a patient have underlying tinea pedis or untreated stasis dermatitis, or even a concomitant ectoparasitic infection that leads to a recurrent bacterial infection? For the reasons we spoke about earlier, consider Group A strap coverage, and consider working with a local pharmacy or clinic for medication storage. We've done this for patients who require biologic treatment. The pharmacy at BHCHP has been kind enough to store medications for patients, and this is often done at some of the shelter systems as well. Una wraps, gentian violet, and Castellani's paint can be quite useful in the management of chronic venous stasis and wounds. And admission to the medical respite center may facilitate care, as we've discussed previously. I also wanted to mention that there are innovative programs underway across the country to help the health of this population. This mobile van provides showers for patients in California. And they've actually partnered with this organization, The Right to Shower, and purchasing products through their website actually helps to support the hygienic stations. Our own department has collected cosmetic and hygienic items for women experiencing homelessness, and so many of you participated in this drive. I do want to mention that Bombas donates a pair of socks for each one purchased, and the Boston Red Sox have been incredibly generous to our organization. Prior to the COVID-19 pandemic, the Melanoma Foundation had established sunscreen dispensers in public areas that were available to our patients. And it's creativity and efforts such as those programs that lead us to legacy. Sammy has left a legacy of compassion and community partnership. In the final portion of our talk, I'd really like to discuss the legacy of our community. You'll notice many familiar faces on these slides, and that's really what makes me the most proud of our program. While there are so many strong bridges between our departments that connect patient care, research, and education, this bridge connects community outreach, and it is rooted in social responsibility. While it may not generate much financial revenue, it comes from our hearts and it generates hope where it's most needed. It makes me feel immensely proud that the specialty of dermatology and our departments value this important work. It's been the honor of my career to stand beside all of you to advocate for some of our poorest neighbors. Our program deeply appreciates the time that all of you have spent providing care for our patients, conducting skin cancer screenings, participating in fundraisers, donating to fundraisers, and assembling skincare kits. You are all an important part of this legacy, and I'm deeply grateful. So let me tell you a little bit about how it all began. I'd say that our model has followed this quote by legendary nurse Barbara McGinnis: follow your heart, just do whatever needs to be done next. When Ernesto began to provide informal rounds in 1998, there wasn't much of a plan other than to help a community greatly in need. It wasn't until nearly a decade later in 2009 where his dream to incorporate this experience into the Harvard residency training became realized. Through a patient-centered service learning model, we initially started with a monthly clinic before recognizing the need for a more consistent presence. Over the past several years, we've expanded to a weekly clinic, as well as a bi-monthly pediatric and family clinic, in addition to some special programs, which I will discuss. Our collaboration officially began in 2009 with the goal to improve dermatology access for men, women, and children experiencing homelessness in Boston. These are the primary care providers at Boston Healthcare for the Homeless program who have been so essential to the success of our partnership. They've also trusted us with the care of their patients and allowed us to share their medical home. And this is the living legacy of dermatology in homeless medicine, which began with Ernesto so many years ago and is now a small and enthusiastic gang. In addition to Ernesto's clinical care, we are so grateful for the service of Dr. Adam Lipworth, who spent over 5 years as an attending at BHCHP before becoming chair of Leahy Dermatology. He still participates in every skin cancer screening and consults when we have complicated infectious disease cases. I'm so grateful for my partner, Dr. Molly Kavanagh-Hussey of Brigham and Women's Hospital, whose outstanding clinical care and public health expertise have contributed enormously to our program over the past 7 years. Molly and I currently rotate staffing our weekly clinic at Boston Healthcare for the Homeless program, where there is never a dull moment. We are so indebted to the service of Dr. Marty Mim and Dr. Adriano Pires, who have also been processing and reading biopsy specimens at absolutely no cost for the past 10 years. Their generosity and commitment has been an integral component to the diagnosis and management of skin disease in our patients. In addition to the patients that we care for, one of our favorite aspects of the clinic is the opportunity to work with residents. A secondary goal of the program is to provide our trainees with a valuable learning experience. We seek to teach empathy, cultural competency, and management of skin disease in a limited resource environment. And we feel that preparing our residents to care for this population is both necessary and valuable, and each resident is actually able to rotate with us in clinic before they graduate from our training program. To our residents, we appreciate your interest in learning and your important contributions to the care of our patients. What you may not recognize is that many families experiencing homelessness in Boston are displaced to communities outside of Boston with minimal access to transportation. So it's really best that we travel to them. Here are some photos from one of the family sites in Waltham, the Home Suites Inn, which is a motel that houses families experiencing homelessness. Our clinical space shown here is a converted motel room. We also travel to St. Mary's Family Shelter in Dorchester. And here's a photo on the bottom left of the supplies that we need for clinic, which is essentially 2 portable cases and a liquid nitrogen canister. As dermatologists, we are very fortunate to be part of a medical subspecialty that can essentially create a pop-up clinic and perform biopsies and even treat early skin cancers. Foot soaks have been offered to patients of VHCHP and conducted by nurses and clinicians as a way to demonstrate empathy and build trust. Expanding on this idea, Dr. Diana Bartenstein, one of our current residents, created the Spa Days program. This initiative, which stands for Skin Empowerment for All, uniquely partners an element of self-care, such as a face mask, a foot soak, or a hand massage, with skin education. Here's one of our Tufts medical students applying a face mask to one of our patients, and this is an example of the educational materials that are used during the sessions. The data collected at Spa Days by Diana have been fascinating. We found that this successful program not only boosts self-confidence among participants, but also reduces immediate stress levels. It's been estimated that about 40% of individuals experiencing homelessness are women. And so programs such as this that really focus on mental and skin health are very important. To provide costly over-the-counter products to our patients, we've created these unique skincare kits. As you know, over-the-counter products are the foundation of skincare management and are not accessible to our patients. Partnering with our generous skincare companies and led by the power team of women shown here, we developed kits that are tailored to treat various skin disorders, including acne, eczema, and baby skincare. Each kit contains about a week's worth of sample products, and these kits have been very well received by our patients. Supplying these kits seems to be a unique point of engagement for medical care, as patients will sometimes return to clinic to pick up their next kit, and that's a convenient time to remind them that they might need a blood pressure check or a blood sugar monitoring. Here's a photo of the assembly process at Mass General, and we are so grateful for the work of Lynn, Samantha, Nira, Lindsay, and our own Luelle for making this project possible. During the COVID-19 pandemic, we switched gears and assembled COVID care kits, which include basic hygienic items such as hand sanitizers, COVID informational pamphlet, and even puzzles to keep patients busy while they were undergoing treatment for COVID or even quarantined within a shelter. This project was developed by Haya Rafe, a fourth-year medical student at Tufts, who worked tirelessly to solicit donations and assemble kits. These efforts have been recognized by the American Academy of Dermatology and the American Medical Association. Over the past 2 years, with the help of Dr. Shinjita Das and Dr. Fiatsabi Dizali and the Mass General Center for Telehealth, we launched a new teledermatology initiative that involved the creation of a platform so that providers of homeless medicine can send us e-consults using an iPad. This has increased access to care among some of the remote sites and has also helped with more pressing dermatology consults in the medical respite center. Each year prior to COVID, we offered skin cancer screenings for patients who were staying in medical respite. We're very proud of this event, which involves participants from all dermatology departments at Harvard. I apologize that I can't individually thank the 130 faculty, residents, students, and staff who have volunteered for this event, but want you to know that we deeply appreciate your time and your expertise. And unlike other skin cancer screenings, we're actually able to offer biopsies and treatment for other skin problems at the time of the screening. As you could see from the prior slides, trainees play an integral role in the care of our patients and in our programs. In 2019, we were able to establish a funded medical student research position in Ernesto's name. Fiatsabi and Lindsay, both future dermatologists, were the first 2 Ernesto Gonzalez Fellows in community dermatology. The residents shown here among others, have played enormous roles in the creation of our programs that would not exist if it were not for their enthusiasm, their creativity, and their commitment. And as participation in community service may enhance empathy and professionalism and reduce medical burnout in the long run, we are proud that this clinical experience is a part of our training program. In conclusion, I'd like to connect back to the three themes of our talk. Patients experiencing homelessness have unique dermatologic needs that we can treat through compassionate, patient-centered care. We can partner with primary care providers to develop innovative ways to meet the needs of this population. And finally, we are all part of the solution to end homelessness. I think Sammy and David would appreciate these words spoken by Ted Turner. Music has a great power for bringing people together. With so many forces in this world acting to drive wedges between people, it is important to preserve those things that help us experience our common humanity. I agree with Mr. Turner, but I would also argue that in addition to music, the themes of today have the same power to bring people together, showing compassion, partnering towards a common goal, and building a legacy rooted in social justice. Thank you so much for your time today, and thank all of you for being part of this legacy.
Thank you, Jen. That was a wonderful and inspiring talk, and I think really fitted well with the theme of today's memorial lecture. I'd like to open the floor. We have a few minutes for questions. If you permit me, I'd just like to open it up with one of my own. I think you commented on this in the lecture, that one of the things people always have this preconception about is that follow-up would be difficult in this kind of situation. But you also commented how practitioners know every detail of the patient's lives and how they can kind of find them, know where to find them on any given night. Is that information also tracked in a medical record, so that if that information is kind of persisted, so if there's a transition in care or a provider is away, that follow-up can occur?
That's a great question, Gideon. So at BHCHP, we actually utilize Epic. And as you know, there are different tabs in Epic where you're able to include notes about one's demographics. And so, yes, that information usually, if email is the best way to contact a patient, or a phone number, or through one of the shelters that they normally stay at, that information usually is on hand.
Fantastic. I would like to open it up to the floor if anyone wishes to either unmute themselves, or if there are particular questions, you could always put them in the chat if you.
This is David. I would just like to extend our enormous gratitude, Jen, for the incredible work that you're doing. It's a source of indescribable pride for all of us in our broad community. This is a service to those in greatest need, and stay strong and keep pushing forward. We're enormously proud. Thank you.
Thank you, David.
In that theme, I'd like to actually follow up. I wanted to thank you for showing so many of the other people in our department or departments, because this is a cross-Harvard effort, have really participated in this. But what would your advice be to anyone who actually wanted to get involved in this work, who hasn't yet been? How to either launch something like this, or how to become involved in your work?
So, I would say that starting small is always a good first step, and building, I think that we really tried to emphasize here that community partnership is very important when working with vulnerable populations. And so if there's a particular population that you're interested in working with, making connections with folks who are already on the ground is important. And I think as a medical subspecialty, partnering with primary care is imperative, because especially with our patients, they have enormous trust in the primary care providers who they are used to, they've developed longitudinal relationships with. And if a primary care doctor is going to recommend seeing us in clinic, they will often follow through. And so I think that partnerships are incredibly important.
Fantastic. We do have one question in the chat here. Laura Torres wrote that excellent presentation, Dr. Tan, powerful and inspirational. Many practical ideas to explore in variety of communities. What has been the most challenging part of this program implementation?
It's a great question. We are, at least when we were first getting off the ground, I would say figuring out how to fund this program was a challenge. And I'd have to say thank you. At that time, I was at Brigham and Women's Hospital, and Dr. Cupper and the Norman Knight Foundation were, along with Dr. Gonzalez, were able to contribute a small fund of finances to be able to get this under the ground. It took about $5,000 to get started initially to purchase the supplies needed. And I would say, so initially just getting things started and figuring out how we would incorporate into a medical record system that was different from our own. But now I would say the more challenging piece of it is, now that we're quite busy, is the coordination of care. We don't have a ton of administrative support and I think that trying to do the follow-up for patients does require quite a bit of time afterwards, especially when patients do require treatment for different skin cancers and surgical interventions. And so that in particular, and making sure that the patients who have these large skin cancers actually make it to their appointments for surgery, and that they have good post-op care and that their outcomes are good, has been particularly challenging. So I think we're at the point right now that I think we're almost ready for expansion in terms of our team.
Fantastic.
This is Lynn. I have a question, if that would be okay.
Of course, go ahead, Lynn.
It's not so much a question, it's both a question and a thank you. I want to thank David and Claire for enabling this wonderful lecture on behalf of Samuel. It's inspiring and it's important, and it shows what a person who unfortunately is lost to us this day has stimulated and fostered. And this is an amazing presentation, Dr. Tan. I just love what you've done, and my congratulations to you. But I think, and I also like to thank Peter Slavin for his remarkable comments. I think the comment that was made about him giving the coin back when he was in Israel was just, it made me cry. So I just want to thank you all for a presentation. Now, the question I wanted to ask you is, can you provide perhaps a list of things that many of us could contribute that would be helpful? I mean, whether it's clothing or shoes or money, or it might help people understand how to be more involved and help fill in some gaps. Is that a possibility?
Absolutely, Lynn. And I appreciate your comments, and I appreciate your willingness to even contribute. I think that there are the needs of our patient population is varied across the system. The needs in the family shelters are much different than the patients on the street teams. And so if it would be helpful to put together, especially for not only dermatology specific goods that can be helpful for our patients, but basic items such as shoes and socks and hats and gloves in the wintertime, I'm more than happy to put that together and really appreciate your interest.
Thank you.
Well, I do want to be respectful of people's time. I think this has been a wonderful first inaugural lecture. I'd like to take a moment to just say thank you, Dr. Tan, for sharing your work and your experience with us today. Truly inspirational. I think this is absolutely not what people generally think of when they think of dermatology, and I appreciate the way that you are representing both us and the specialty. I also want to say thank you to Dr. Slavin for helping us to mark this occasion, and also, of course, to the Fisher family for initiating this lecture series, and to all of the friends and family that joined us here today for this inaugural memorial lecture in Sammy Fisher's name. Thank you.
Thank you.